Karli, thank you very much for talking to me. It's very kind of you.
Yes.
Whereabouts are you?
I'm Portland, Oregon. So here in the Pacific Northwest. And here in Oregon, we've been fortunate in that our government shut things down pretty early. So we haven't had the spread that we have seen like in the Seattle area, down in California, and certainly not in other places on the East Coast. So it's been in the beginning when the CDC was recommending airborne precautions for these patients. And so in the beginning, it was a little bit anxiety inducing in that most of the airborne unit rooms are on my unit. So we kind of learned about all of this right at the get-go back in mid-March when we started seeing cases at our hospital. And then after that, they loosened that up to droplet contact precautions. And so those patients are being cohorted on other floors now. Of course, our specialty patients would still be on our floor, but for the most part at our hospital, we're trying to cohort those patients onto certain floors that, just to maintain safety of all the other patients in the hospital. Cool. And at that time, we started, we stopped all elective surgeries and the hospital started emptying out. And so we really were at maybe, 20-30% capacity there for most of April. And now we're adding those back on. So our hospital filled up really fast again. So I'm a little bit nervous with, as of Friday, the 15th of May, 31 counties have reopened here in Oregon. And with the exclusion of Multnomah County, Washington, and Clackamas, and I believe Marion and Polk as well, there's been a small outbreak in a nursing home there, which I believe 41 residents have tested positive and 4 have died. Because you have to meet specific criteria, in order to open, and you have to have, I think, 15 contact tracers per 100,000 people. You got to meet a lot of different criteria. Now, this does not include shopping malls, shopping centers, but, with very strict criteria, they can reopen small businesses. So we're not in that county.
Yeah, so just as an ordinary private citizen, you've been fairly closed down. I mean,
yes.
What's it been like for people there over the past sort of couple of months? It's the 18th of May now, isn't it? So we're talking,
Yeah, it's been almost 2 months now of just being home. Maybe once a week going to the grocery store. We don't. If there's cause for concern, you could get pulled over by law enforcement if you're outright, breaking the actual mandates. But overall, I think most people have been pretty good. But I think that people are starting to get tired. We've got the stresses of the economy. People are starting to say, to hell with it. They're just dying to go to the beach. I think they had 700 people drop in on Cannon Beach. We were a small community on Mother's Day weekend, and that's disappointing. And so it makes me nervous because I think that there's always going to be a fair amount of the population that just for whatever reason is unable to abide by the mandates that puts other people at risk. And so one thing I'm excited about that I want to tell you about is, let's see, the Oregon Health Authority in collaboration with the hospital I work at, as well as, and this is all public information, Portland State University, which actually is where I got my English degree back in the day. They're all collaborating on a huge study that they've just started, and they've just mailed out letters. So 100,000 people, 100,000 Oregonians will be traced. They'll voluntarily track their symptoms daily. And of course, if they start to have symptoms, they will have a test kit that's been mailed to their home. So this is a huge study, and they're hoping that this will, so you'd have something like this. I'm actually tracing symptoms at the moment. So you got, paper like this.
Yeah.
And you'd write down your temperature morning and night, and then you'd be tracking this cluster of symptoms that kind of go along with it. So
what are the symptoms there, Karli?
On this one, it's fever, cough, shortness of breath, sore throat, body aches, chills, headache, diarrhea, and nausea and vomiting is the last one.
Does it mention lack of smell?
No, it doesn't on this one. It doesn't on this one. There's also been there's been the Abbott test is the rapid test. I don't know that they're the only manufacturer. I doubt it, but the Abbott rapid tests have been showing about a 48% false negative rate. So
that's the test for the virus, Carly. The test, yeah.
Yeah, and of course, some of these are the ones we use post-procedure just to lessen the amount of PPE. So if you're coming in for any kind of a procedure, and especially one that could involve any aerosolizing procedures, you have a pre-procedure test, whether you're symptomatic or not. And those have to be resulted within 24 hours of the procedure. So we're doing lots and lots of those. And then we're doing the one-offs for patients coming from facilities, nursing home, long-term care facilities, Alzheimer's memory care units. Unfortunately, if we're not getting an accurate result, that's leading into potential exposure. So
48% is just huge, isn't it? I mean, it's like using 50% more PPE than you need to. It's incredible.
I know. But so at my hospital, they went on masks on policy, I think in early April, maybe the first week of April. But these are just procedure masks. They're not going to protect us. They're hopefully protecting all of our patients. And we're to use one for 8 hours without changing it out if we can.
Wow.
So
it's going to be soaking wet by then, isn't it?
Yeah, and it's definitely it just doesn't. So it's good that it protects potentially the patients, but we're nowhere near testing where like we could test someone every day they're in the hospital, because at any given point in time, it's possible they could turn positive. And if you test too early, you may not have enough virus to show up on the test. And so I would love to see where we're testing every patient every day. We don't have the PCR tests yet. We just have these rapid 24-hour tests, or otherwise it takes, actually, I think the rapids result within about 6 to 12 hours. And then I think the other ones are going towards 24 to 48 hours now.
So it's this other test that's giving the false positives, is it?
The rapids, yeah.
Yeah.
And I believe
I've never used those. So it's not a PCR test. It's a simpler test.
Mm-hmm. It's
Right.
a nasal pharynx swab, and it's done by the company Abbott. And I know the FDA, as of last week, recommended pulling those. So I'm trying to verify which company our specific tests are coming from. I don't know.
That's okay. Yeah. So are you doing any antibody testing? Do you know?
No, not widespread. I think there's been a few facilities that have had access to them. I have a friend that works at a different hospital, and she was able to get an antibody test with a doctor's order. But yeah, they're not seeing those out there yet.
No, and that would be a venous blood test, so it's a bit sophisticated, isn't it? It's someone
funny,
like you would have to take the blood.
Yeah, it's funny though, because 6 weeks ago, and you were even talking on this video about that, I thought, man, they'd be coming a lot sooner than they have.
Absolutely, I was expecting them ages ago. Yes.
Yes.
There'd be cupboards full of them by now. It's very disappointing.
I know.
Yeah. So you're a registered nurse, aren't you? You work at the local hospital.
Yes.
Yeah.
Yes.
So how many COVID patients are, obviously we can't talk about individual patients, but are you seeing a lot of COVID patients coming in?
On average, we've had about like 7 to 10 on any given day in-house.
And that's for that's for what, like an area of Portland, or?
So we have a cluster of hospitals here in the Portland area, and those are actually what's the word? They're combining. There's a centralized task force that sort of splits these patients out evenly. They've done a lot of really good work. I know the hospital I work at has a very strong COVID task force. We have a wealth of information and flow sheets, and we have a doctor 24/7 we can page with any question. I mean, there's just been a lot of support. They've given us 120 hours of sick time to encourage anyone with any symptom like a sore throat to stay home. And then you track your symptoms. And so giving us all that extra sick time was great because it incentivizes people to stay home.
So really good idea to protect colleagues and patients, isn't it?
Yeah, and then they protected our income as well. when we had the low census back in April, we were overstaffed, obviously. So we all took turns getting leave with pay and staying home, which was really good to try to work through some of the anxiety and that, especially for healthcare workers. I know you posted some videos on it last night, and I'm so glad you did. But it really helps with
the anxiety, the stress.
Yeah, the process, and also just to look through the COVID website and make sure you have a really strong understanding of when these tests are indicated and how long you keep them in contact droplet. Right now, most of the rule outs, we have to have 2 negatives. So we keep them in contact droplet for that amount of time.
So you mentioned elective surgery was suspended and other services were suspended. Do you feel that there's people suffering from morbidity and potential mortality as a result of all the resources going on to COVID?
I do. I think there's a lot of fear in coming to the hospital, and we see it sometimes with our. We have a lot of patients with chronic disease such as heart failure, and so waiting just too long to come in to start getting diuretics, and you have 40, 50 pounds of fluid volume overload, and
you're seeing more advanced pathologies being admitted then.
Yes, and then also we have no visitors allowed. There's exceptions to that. If a patient is at end of life and dying, they can have 1 visitor per 24-hour period. So you can't be switching out every hour, every 2 hours. And that's been really difficult for patients to be isolated from their family during times of health crisis. And so just from a nursing standpoint, we have some things like we've been donated some tablets. We can kind of facilitate face-to-face like we're doing right now, which helps, but it's just not the same. And so another exception that they did make was for patients with dementia or delirium, they are now allowed to have 1 visitor, which really helps their health course to have a familiar face there at the bedside.
Absolutely, yeah.
Yeah.
Yeah. So the hospital's divided up, is it, between COVID areas and non-COVID areas?
As much as we can. Of course, if we had one of our, like I said before, if we have one of our patients such that has a VAD or they've had a heart transplant, they kind of look at it a case-by-case basis, but we'll try to keep those patients on our floor because our nurses are specialized to care for those patients. So,
of course. How's your health been personally, Karli? Have you kept well?
Well, I had a sore throat and a cough for about 10 weeks. Sorry, about 10 days ago, about 2 weeks ago. So I was home for about a week, and then I did get tested, and I was negative, thankfully. But some of us have possibly been exposed over this last week, and so we're now tracking. That's why I'm tracking for 14 days. I fell into the moderate risk category for my level of exposure. Sometimes it just, I think they might have some symptoms. Let's run a test. They're positive. And then you have those situations come up where you have potential exposure over the course of 1, 2, 3, God knows how many shifts that they may have been shedding the virus. So
indeed, yeah. And even before they were symptomatic,
Yeah, and and that's what I say. Like, I would love to get to the point where we can just test every patient, even maybe every employee, every single day with something that's maybe not quite as invasive and uncomfortable as those nasal swabs. But we got to have accurate testing, or what's the point?
Yeah, some sort of scanner or something, almost like taking a temperature, would be pretty wonderful, wouldn't it? Then we would know.
Well, yeah, and we have a policy too with this is a huge mindset change from the nursing that I've come from. I've been a nurse now for almost 6 years, where you just jump in and then you kind of cry later about, oh man, I didn't even have time to grab gloves. I jumped right on the chest or whatever. And we absolutely cannot do that, period, until we get the actual face mask, the N95 on, and a full gown before we can lay hands on the chest. So that's definitely
like scratching your nose, though, isn't it? You just do it automatically without thinking about it.
You do, and there's actually been nurses that have died from being exposed. So cardiac compressions are an aerosolizing procedure.
Yes.
But you wonder, they take the obvious ones like use of CPAP, BiPAP, cardiac compressions, but you wonder, like flushing the toilet and talking.
Well, flushing the toilet is a known risk.
Yeah, so like we should have
especially from stools, and perhaps from urine as well, but certainly from stools, it's a known risk. And again, talking is a known risk. That's the whole point of masks, to take away the momentum from the flow of air.
So we just don't have the PPE if we have to treat every patient, unless we have a result in the last, I believe it's 48 hours, we have to treat that patient like they could be positive. So there's, only 2 people allowed in the room. We can't, I don't believe that we can even bag them. We have to wait until they come to intubate. And so our codes have changed a lot. Fortunately, we haven't had one on our unit yet. But we're running through mock codes and things like that so that we're ready. But it's all, just as well as I do, it's the time that you get to the chest. And so we have PPE bags on our code cards, but even if it's a 30-second delay before you get gowned up and get onto the chest. And then they've got a Lucas device, so you put the patient on a backboard and you slide that under, and it manually compresses. So that way it minimizes the amount of time a human being is on the chest potentially being exposed. So
I suppose ideally, I've certainly resuscitated patients without doing any basic life support by just instantly defibrillating them. So if that's possible, that's the ideal situation. Then there's no or limited aerosolization with defibrillation, I would imagine. But that depends on being monitored and having the right equipment and the right expertise and everything available immediately. So what's your impression about the sort of stress levels in the hospital generally? Do you think staff are getting quite anxious and tired? And
I think I work with an incredible team on my unit, and I think everyone is going through things. I think that at work we try to come to work with sort of a positive approach. We know that everyone's kind of going through it, and you don't want to be the one that's like, this is hard, and being the one that's dragging your team down. But certainly on our days off, we're messaging each other and kind of trying to support one another. And just they talk about toxic positivity, where you're like, well, just put your best foot forward. But it's important too to be honest with one another about what we're going through. So OHSU, everyone's got their own ways in which, their personal therapist they might see, or their own self-care strategies. Me, I'm a huge native gardener, so I've been spending lots and lots of time out in the garden. I'm fortunate to have one. Not some people live in apartments or whatever.
Yeah, I'm the same. I love growing things. Yeah, I've gotten a lot. Love it.
Yeah.
Lifesaver.
We have a lot of support at OHSU. They have several wellness rooms, or maybe it's just one, but different companies have donated things. You can put headphones on, listen to meditation. There's yoga mats. There's fresh water bottles. It's a quiet place you can go to just decompress while you're at work. And I know right now they're running a survey trying to get a pulse for how people are really feeling. And of course, if you can put that into a survey, they can kind of try to get a sense of what the underlying stress level is amongst our employees, and then address that accordingly. So I filled it out the other day, and I was surprised by some of my answers, because when you went over the questionnaires last night, and you mentioned how it gets you thinking about yourself. Sometimes you know that you're feeling stressed, and it's just constant, but you maybe didn't think about it in that specific way, that, like, for instance, you haven't been able to sleep well, or, so very glad that OHSU has been in a state of proactivity. I think everyone was kind of scrambling in the beginning, but I think we're at a place now where we're coming from a proactive place, and we have guiding principles, or, transparency with the community and things like that, that I think are so important too.
Yeah. So have you had colleagues who've contracted the virus?
Yes. There has been 51 employees that have tested positive. 20 of those 51, I believe, was a result of direct patient contact. So contracting it from a patient, and then the rest would have been from the community. So
of course, if you catch it, you don't necessarily know where you caught it, do you? It could have been caught in the
Yeah, and I was just reading that Marion County, so our state capital is in Salem in Oregon, and that's Marion County. They've got the most cases and spread down there. And they have been unable to trace 40% of the cases, which is what I was just reading today, which indicates widespread transmission.
Yeah.
So that's concerning too, when you can't, the contact tracing we don't know where it came from.
So there's no epidemiological link in 40% of cases.
Mm-hmm.
Yeah, indicating cryptic community transmission, I guess. It's yeah. So I was reading a study today about Boston, and about 10% of the population there seems to have been infected. In Spain, it seems to be about 5%. So, you know, this pandemic does seem to have spread further than people have thought. But I think there was disappointment in Boston that only 10% of people have been infected, sort of looking towards herd immunity. I mean, what's your kind of impression there? How many people do you think have been exposed to this virus in Oregon?
Oh, minimal. I think we've had, I mean, we always know it's higher, but I think we've only had just over 1,300 positive cases in Oregon. And
right. And that's despite quite a bit of testing.
Yeah. So I'm hoping that this Key to Oregon study will shine some light on where the community spread is and give us a little bit more information. It's a huge study, and you know, it's got a lot of great institutions behind it. So, but you know, without the antibody testing that we still have yet to see out there, it's just, I still feel, and it makes me nervous.
Frustrating, isn't it? You just want to know.
I know, in 31 counties reopening, you know that there's, if we have 40% of cases that they can't contact trace in Marion County, we've got 31 counties in Oregon reopening. We just don't have that infrastructure quite there yet to make this, for me to feel confident that we're still going to be flattening the curve enough that's not going to overwhelm our healthcare systems. So,
but given that the virus is out there, given that restrictions are being limited, it's hard to see how there's not going to be more cases, isn't it? It's
oh yeah.
Do you see an inevitability there somehow?
Yes, I do. I think that that's where my anxiety comes from. Is I feel like, you know, we should be like at the end of the road already, but no, we're in the very beginning stages. So I am trying to really take advantage of my days off, get myself in as good a shape as I can. I've actually stopped drinking altogether. You talked about
well done.
Let's just get rid of any possible thing that could make me feel poorly physically. Trying to eat better and spend a lot of time outside, and then get to work and hit the ground and be ready to go, because I really don't know what's going to happen from week to week. And I know that we're going to be starting to see more cases again. So
it sounds like your kind of best guess, though, is less than 5% of the population so far exposed to the virus.
Oh, in Oregon?
Yeah.
Oh, for sure.
Less than that, yeah.
And especially because we locked down so early, it hasn't had a chance to.
Right. So this is excellent in that you've prevented a lot of cases.
Yes, very. And that, when I have to remind myself, like, look at what a great job Oregon has done. Look at what a great job your hospital has done. And I take a lot of confidence from that, because we have the best people working on this. We have the best of the best on our task force.
Sure.
And yeah, so
good public health infrastructure. Yeah. Wish it was the same everywhere. Excellent. Delighted to hear it.
I know. And
so you've kept the curve fairly flat in Oregon.
Yes.
I think this is the thing about the United States, that the response is pretty well depending on the state. So there's been very disparate responses. So you get a brilliant response in one area, and you get a response I would call negligent in other areas. And you end up with this sort of higgledy-piggledy sort of mismatch across different states. But then, of course, people can travel between states, so it kind of underpins it, doesn't it?
I know. And we have had an excellent response in Washington State, Oregon State, California State, so that the whole West Coast. But then you have the other states where it's really worrisome, and people even being violent with one another when you try to enforce. If you're going to come into my store, you need to wear a mask.
Yeah.
I would say the culture here is if you go to a grocery store without a mask, you're going to be feeling some social frowns.
That's good, isn't it? Making it socially uncomfortable.
Yes.
Unacceptable, not to be looking after other people.
Yes. And, Portland especially, I don't know that it's like this in some of the rural communities of Oregon, but, Portland is most of the cities are like this, but it's pretty liberal. I think people want to do the right thing, but we're also coming from, a place of privilege. You look around, you've talked many times on your channel about other countries that just literally don't have access to clean water to even wash their hands.
Yeah.
And so I sort of feel like it's when you come from a privileged community and you're able to do whatever you can, why not? But to be that person that's like, well, I'm not going to do that. You can't tell me what to do. It's really hard to understand how you could impact your community negatively like that.
Yeah, there is a tendency to claim an individual's rights at the expense of harming other people sometimes
Mm-hmm.
Well, in many cultures around the world, it's unfortunate.
Mm-hmm.
Now, I've got a thing about vitamin D.
Yes.
I think low vitamin D levels are predisposing to different infections, and I strongly suspect it's predisposing towards COVID-19 infections. Now, is that discussed in the States? Is it known in the States? Have people heard of that?
You do see the news story, like maybe under the 4 or 5 of them, you'll see a news story suggesting that it would be helpful, but you don't. I'm not hearing it discussed in the hospital at all. I'm not seeing this sort of prescribed for any of our inpatients unless they were already on it or they feel it would be beneficial.
So it's not like part of the public health advice. It's not like wash your hands and wear a mask and.
No. Okay. And I have some dear friends in Israel. I was messaging. Most people in my age group have parents in a high risk. I'm in my early 40s. We've got parents in their 60s or 70s. Cool. And I was recommending, and they hadn't heard anything like that in Israel. So I talked to my peers at work, and some people have heard of it, some people haven't. Some people already take it because long before COVID, they were told it was a good thing living here in the Northwest. But I don't see a correlation necessarily to reducing the risk with the COVID-19 virus. So
time will tell. I might be wrong, but I don't think so. I think the evidence is coming in my direction here.
I know.
Yeah, I think so. So do you have many large African American population in Oregon? I have no idea.
Not too high of a population. But
because we know the African American population is shorter of vitamin D, and we know they have morbidity and mortality when they actually contract the virus. So, which is concerning, and people just seem to jump to sociological, economic explanations for that rather than looking at things like vitamin D, which is yeah. So tell us a bit about your day job, Carly. What sort of nursing do you do?
So I mentioned about our hospital or our unit population. We have patients that are from different surgical services. It's a cardiovascular intermediate care unit. So we're the step down unit from the ICU, but we're not an acute care floor. So we'll have, heart patients that are in advanced heart failure. They might be on a milrinone drip, or we might have someone 2-3 days post cabbage, or we might have.
Should we tell people what cabbage stands for?
Oh yes.
We're always saying that. We say you had a cabbage last year or something. It stands for coronary artery bypass graft, and it's a rather brilliant procedure. And it's.
Oh, I know.
It does sound good to say cabbage, yeah. Yeah. But no, sorry, I interrupted you. Carry on.
Oh, that's okay. The heart failure patients are my favorite patients. I I love our unit because I have a heart for patients who are at end of life. So that is a patient population that I really enjoy caring for as they come to end of life with heart failure. But there's also a lot of hope, whereas people are able to bridge to a heart transplant or to an LVAD, which is it's a ventricular assist device where you have basically a pump that's put into your heart that helps pump the blood for your weak heart.
Wow.
So
pretty high
so there's
stuff.
hope, but there's end of life, and I love that combination. And then there's a lot of surgical patients. But as of right now, sometimes when the floors that are cohorting our COVID patients are needing to free up beds, we're getting off-service patients that we typically want to take care of. So we might get some neuro patients, or we might get just medical patients that we are able to care for just as well. It's just sort of shifting populations around a little bit. So kind of a mixed bag.
We get a bit of everything everywhere these days. It's
yeah. And then I precept a lot as well. So I always love, I'm like you, I like teaching. I like having my nursing student or my first year nursing practice with me during the day. And it reminds me of all the reasons I became a nurse in the beginning. Because as you go on, you kind of get a little bit tired, or you forget about those initial passions and that's why I loved when you brought up, I think it was like 6 weeks ago, you were talking about how you hope to be injecting the vaccine into arms. That was how I originally went into nursing, is because I went on a missions trip to Africa and traveled with a nurse. And I thought, if I ever come back here, I want to be a nurse or work in some like dimension where I can actually meet felt needs. And so that was how I became inspired to be a nurse. And so when at the time I was doing my English degree, I thought, well, in Portland, there's lots of people with English degrees. A lot of them work in coffee shops or something. And I didn't see myself going and getting a PhD in English. So I started taking electives for nursing, and here I am today. No regrets.
PhDs are generally a bad idea. I wouldn't bother doing it. Takes up a lot of your life.
Yeah.
Yeah.
So I hope to do something like that.
Yeah, no, that's brilliant. Yeah, no, you're right. End of life care is something quite special to actually be there. And you and I have done this many times. To actually be there when someone's life ends is just it's kind of a unique privilege, really, isn't it? It's it's quite a special thing.
Very much so.
Difficult, but remarkably special.
Mm-hmm.
Yeah. Okay, so we're now on the 18th of May, 2020.
And as of today, my particular hospital invested in my retirement plan, 5 years. I have 5 years invested today. I just looked it up. I happened to see, it was 5 years ago. And then, of course, I worked a year in the Dells, which is a community up the Columbia Gorge. I worked my first year in nursing there. So I forgot to mention my hospital is a very focused in on underserved populations. So we do a lot of work with the homeless populations and underserved communities in the state of Oregon.
Is that a big problem in Oregon, Karli? I know you see quite a lot of publicity about California and Los Angeles and places like this with a big homeless community. Is it the same there?
I don't know. I don't have a way to compare the populations, but we have huge homeless camps all over Portland, and
huge.
Oh yeah, and actually with the downtown being shut down right now, they've even increased in population. And I don't have a sense either if the homeless populations are increasing just in terms of our economic situation right now. But yeah, my heart goes out to them right now. And also
people tend to think of the United States as being a sort of affluent, high-tech, rich, go-ahead, socially progressive country. Mm-hmm. And yet there seems to be this pretty well sort of almost iceberg situation of huge numbers of people in really significantly difficult situations that you just don't seem to hear about. Is that?
Portland has a lot of social services, and we had I can't remember the specific history, but I think we have something like 120 some buildings in downtown Portland that used to be, I think they used to be like hotels, but they basically been converted into single occupancy rooms for homeless or low income patients. And so when I was in nursing school, we used to go door to door, and it was incredible. You'd have a Starbucks and Anthropology and these nice little shops on street level, and nobody had a real sense of what was going on the floors above. And so we would go, and people with significant mental illness, it could be hoarding or fear of going outside. It was really deplorable conditions, and this is just actually an upgrade from living on the street. We used to volunteer at a lot of different places around Portland too that provide a safe haven. Actually, one of them is Rose Haven. They have for women, they provide breakfast and a safe place to come in and sort of have community with one another. But it was really hard to see how much fear, because they could fall asleep for an hour and then they wake up and their bags are stolen. So it's just, there's a lot of trauma within this population. And yeah.
And of course, once the virus becomes a cluster in that sort of community,
it would spread very quickly.
It'll spread through the community and outside. So working there, do you see a lot of people with long-term disease conditions?
Sorry, what's your question?
In these homeless situations in the underprivileged areas, do you see a lot of people with chronic health conditions?
Oh yeah, oh for sure. And a lot of vascular conditions, because you've had the underlying pathologies that have been let go for so long. So then you get, you have like an ischemic leg and we're trying to save it, or it's beyond repair. And now you've got a patient that lives on the streets that now doesn't have a leg, and you have to discharge them back to a shelter or to the street. And it's really difficult. And there's always the chance that there is a significant amount of mental health issues on board as well, that obviously are being chronically neglected.
Yeah, and presumably there's undiagnosed diabetes, undiagnosed hypertension, all the chronic sort of metabolic diseases that go with that sort of difficult situation. Yeah, so basically we're describing a large at-risk population there in terms of the COVID pandemic.
Yes. And I think it's similar in Seattle and LA. I think at one time Portland had quite a few. We had more services available, or we had maybe it was, I don't know. It seemed like we got a flow of people coming up from California, and so there's quite a large homeless population here.
Is Portland in the north or south of Oregon? Actually, I'm afraid I don't know.
North. It's right.
It's near Washington State.
I could be over in Vancouver, Washington in 20 minutes.
Okay. Right. Okay.
Yeah.
Sorry for my complete ignorance.
And the Columbia River runs between, and so it's very beautiful. If you ever get a chance to come to Oregon, you'll have to drive up the Columbia Gorge. It's beautiful.
I would love to.
Yeah.
Love to. So the next few months, Karli, how do you see things panning out? Let's say in Oregon, as a representative sort of ruralish state, how do you see things developing?
I feel that we're in a lag time right now. I think that I don't feel we have, I'm a little hopeful with the Key to Oregon study that is starting, but of course that requires participation. So if I'm going to say I'm going to do the study and I only did the first couple of days and then I slacked off, you hope people that if they say they'll participate, they will. But I think there's going to be a lag effect. We shut down, we did a really great job, and now we reopened all but I think 4 or 5 counties, and so you're going to start to see more cases. And so that's why I said
cases have gone down quite a bit with the lockdown. Yeah,
we're getting about maybe 60 cases or so a day. It's not a whole lot, and I think it's been since Thursday or Friday since we've had a death.
Right.
So we've had a few days with no deaths.
Right.
And then, I don't know if all the counties are going to have the contact tracing that's required per 100,000 people. I think they want 15 contact tracers per 100,000 people.
Yeah.
And I don't know that all the counties are able to have that, and they may have been approved to reopen for phase one So we'll see. I'm kind of ready for more cases, though. I think is going to unfortunately be the case. And like you said before, we don't have closed borders at state to state. So what happens in Arizona is going to impact us in Oregon. And, the governor recommends, please, Portland, Multnomah, Washington, Clackamas County, these are huge populous counties in Oregon. Please don't descend down on these smaller counties that have reopened just because you want to maybe sit down for dinner or pretend like life is back to normal. And yeah, I know my husband is Australian, and his family's all in Australia right now. And I know in the beginning, when we were unsure how things were going to go in Australia, I have some of his family live in very small rural communities, and you'd have Sydney-siders dropping down in on these little communities and raiding their grocery stores and things like that. Not to cast any blame, but you have to think about if you're going to travel to a small community, could I potentially be,
of course,
bringing a virus to that community?
You're putting it at risk. There's no question, because maybe 50% of people could be asymptomatic carriers. So yeah. So basically, we're going on to the test, trace, isolate strategy. Is that the way out of the lockdown?
We are, and I don't know a whole lot about how that all is going to work. I just know like how many contact tracers they need. I know that when we have potential exposures at the hospital I work at, they've done an excellent job at contact tracing, but that's within our hospital. You would expect that.
We're talking about a population scale here, aren't we? It's a 10, 20, 30, 50 times more people involved potentially than.
And you also have to, contact tracing is reliant also on, I was trying to think that if I started showing symptoms today, could I remember every single place? I think I could, because I'm not actually going anywhere, but.
Yeah. So in the UK, we're trialing an app at the moment. Do you think that would be, so in China, Taiwan, that there's an app that sort of pings when you've come into contact with someone who's at risk? Would that be tolerated in Oregon, do you think?
I don't know. I think there may be a certain percentage of the population that's always going to be like, you're not going to track me, or you're not going to tell me what to do. But I think there'd be a fair amount of people that would use it. I haven't heard anything about an app being rolled out in Oregon. Having said that, I've been using the one you've recommended, and it tracks how many people in your county are using it. And we've had enough here I'm actually just on the border between Multnomah and Clackamas County, but I live technically in Clackamas, and that this app has enough people to actually give us useful data now using the app as of.
Oh, that's excellent. That's the London one, isn't it?
Yeah. So.
That's great. That's gone international. I think there's about 4 million users on that now. So.
Oh yeah.
It's that app that's changed the policy in the UK to put loss of smell and loss of taste down as one of the criteria with cough or fever for self-isolation for 14 days. So useful information coming out of that. Very useful. So what about the rest of the United States? Do you think, my impression is most people in the United States would cooperate with this sort of thing, or have I got that wrong?
Yeah, you always say that you don't want to, get political about it, but
no,
and I don't want to either. But I think there's just a fair amount of people that don't want to be tracked, or honestly don't. Still, there seems to be a fair amount of people, especially in some of our states, that don't seem to appreciate the actual risks with this.
Yeah,
they sort of cheapen it or dub it down a little bit so they wouldn't be likely to be using anything or tracking anything. So
okay, that's interesting. Yeah. So in Oregon and the States generally, I think what we're both saying is that this is going to at least rumble on for the rest of the year.
There's going to be a
constant stream of cases. Lifestyle is going to have to change at least for the rest of the year. With the social distancing, the hygiene, the mask wearing, and all those other things. It's a bit of a long-term job, this, isn't it?
Well, yeah, and if you think about it, I mean, let's say that Oregon continues to do excellent with their contact tracing, and we're able to keep the numbers down. I mean, we gotta stay the long course, because as you said, we're probably not going to have a vaccine until maybe mid next year. So this is going to be a constant slog.
Yeah. And the
Where
60-70% for herd immunity is not going to come till then either, I wouldn't have thought.
No, and honestly, I hope we keep it down, and I hope that like by the time we start giving people vaccines, and of course there's going to be a percentage of people that'll refuse the vaccine, but that's okay. Hopefully by then we'll still have low percentage numbers that aren't. I don't want to get to 60% before we get our vaccine, because that'll mean a lot of deaths.
Yeah, absolutely, because 60% of the population is many people, and half of them are probably going to get symptomatic disease, and 20% of those are going to be quite ill, and 5% of those are going to be critical, and without the facilities that they're probably going to die, which is I was just talking today about Brazil and Chile, where the hospitals are at breaking point already. So if the cases carry on rising, beyond the ability of the hospitals to cope with those patients, because they haven't flattened the curve out enough. What do you think will happen to those people that aren't getting access to medical care?
Oh man, I mean, I think about when things are the busiest on our unit and we're at full capacity and we have really sick patients, and sometimes you're just trying to cover all your bases, and you hope nothing gets missed, but that if we were even overwhelmed beyond that, then the healthcare workers get more and more tired, and the work gets more and more challenging. And I mean, these are not easy patients. These are patients that maybe have lots of comorbidities. We might be using ceiling lifts. They might be needing constant support with respiratory therapy and oxygen and CPAP, BiPAP. You're gowning off. All of that is so exhausting, and so all of those
factors, a heck of a lot of input, isn't it?
Yeah, and that's just even when we're at full capacity. When you get close to breaking point, I mean, that's breaking point on many levels. It's not just, I think that they're incorporating the breaking point of the doctors and the healthcare providers, the breaking point of not being able to have any patients, all the patients get the healthcare needs met that need to. And so then you wonder, like, well, are we thinking about home health? Like, how many of these patients could we be putting in a home health situation and getting some support there? I don't know. We have a work deployment force. So if we need to pull nurses from other places to help come support us, we can. Or like when we were low census, some of us were being deployed to other functions and jobs, maybe working on the phone, taking calls, working for occupational health. Sometimes, some days, some of us were even door greeters, just enforcing that visitors are not coming into the hospital, and that every employee doesn't have a symptom when they come in, and all of that. So
but you're a sophisticated center, aren't you? You can do that.
Yes, I know, exactly.
Yeah, it frightens me what's going to happen in less sophisticated centers, I'm afraid. It's
I know. And some
the
of
case fatality rate will rise, I'm sure.
For sure.
So I'm fascinated by this mission trip you did before you were a nurse. Well, where did you go, Karli?
I went at one point in my life, I actually went to Bible college, and I was with a missions trip there, and we teamed up with World Vision, and spent 6 weeks in a small village called Baranga off of Lake Victoria.
So
and we built
which country is that?
Uganda. And then I went on another trip. Some of the team stayed behind, and some of us broke off and went into South Sudan for 10 days, and we were bringing support to the refugee camps. And
when was this?
This was in 1998.
So it was a very dodgy place, South Sudan, in 1998.
I look back on my younger self and I think, wow, Karli.
Yeah, I'm afraid I'm the same. I look back and I think, how come I'm here?
Yeah.
Something very strange going on here.
Yeah, I mean, I remember one time our Jeep broke down in the middle of the jungle, and they said to stay in the middle of the road because there were landmines on the sides of the road.
Snakes in the jungle.
Oh yeah. Bandits
on the road.
But the people, I still communicate, 20 2 years later, I still am in contact with friends I made there, and I haven't been in a place yet in my life where I've been able to go back, but it's going to happen, and I'm getting there now. I'm getting closer and closer. And it's just something that you said about injecting vaccines into arms that it just awakened that part of myself about remembering the global perspective, to never forget that global perspective, because it's not just about what's going on here in Portland. I mean, we can't take on the world's problems, but I think just having an open heart and an open mind, and also just remembering how blessed we are here, and what can we do to support. And like I said, we have underserved populations right here in Portland, so you don't have to go all the way, to Thailand or South Africa to treat an underserved person. So I think it's good to remember that.
So something like South Sudan, where the health infrastructure is limited, what are the living conditions like? Do you think they would be amenable to the spread of the virus, or?
Oh yeah, for sure. I mean, I don't think it's. I mean, even in the, like, I remember even being in Kampala in Uganda. I mean, it was just so overcrowded everywhere you went, and in the rural communities, many
of the poor people there wouldn't have access to healthcare at the best of times.
No.
Or very limited.
I remember in South Sudan, I remember people who've been injured in the war. They're just laying on the side of the road. Some people were dying of gangrene or had huge masses. And that's why I said I was inspired to come back as a nurse, because, you could almost just start setting up a clinic on the side of the road and do what you can, and you would make such a huge difference. They just don't even have access to even physically getting where they need to go. So
5% of people become critical. It's not looking good for that 5%, is it?
No.
Between you and me and everyone who might watch, I've got nightmares about the potential death rate in some poor areas of the world. And the reason I say that is not to be alarmist, but I'm really just hoping in some way to mobilize awareness of this, so that something as simple as antibiotics. In 1918-1919 pandemic, which you probably know about, a lot of people died through secondary bacterial infection. And we can treat that. Can't treat the virus, but.
So how would you envision mobilizing, teaming up with larger organizations such as, I don't remember the name of it, but there's a big one that you posted a study.
The David Miliband one, the International Rescue.
Yes.
Yeah. I think some overarching coordination is definitely needed, but perhaps for different parts of the world. But things as simple as quite a few people's lives can be saved by something as simple as giving extra oxygen for a few days. So, establishing some oxygen giving infrastructure for the industrial capacity that we have in the United States, in the UK and Europe. We could bash out millions of these units, and just giving oxygen, not even giving CPAP, not even giving intubation or anything, nothing high tech, that could save a lot of lives. Giving intravenous fluids to maintain renal function could save a lot of lives. Giving antibiotics for secondary bacterial infection, optimizing the control of things like diabetes. With something as simple as metformin or insulin. I mean, you probably didn't notice at the time in Uganda, you weren't medical then, but I've seen people around the world dying through lack of insulin. They just come in diabetic ketoacidotic coma. And all these things are just a matter of a supply chain that I mean, I'm not a pacifist or anything, but if there was a war, they could sort this out. The governments have the infrastructure and the logistics to do this. Just kind of need that coordinated effort to do it, because a lot of lives are going to be quite easy to save, which otherwise could be lost. And at the moment, I see no mass movement. I mean, you do see people like the International Rescue Committee talking about this, but I see no mass movement for it. I hear individuals, I hear NGOs, but I don't seem to see a main people. I think people are so focused, and understandably, on their own difficulties. Because if this disease becomes established in South Sudan, of course it's going to spread from there. It's not going to be isolated there.
We have the problem of not being able to travel there right now either. So
yeah, I think initially it would be delivery of supplies. Because I mean these places aren't without local expertise, and but they're very often without basic infrastructure and basic supplies, basic drugs. So that would be a step in the right direction. But I'm afraid I don't see anything particularly happening about that at the moment, which is a pity. Good, Karli, that was excellent. Is there anything else you think you should tell me? You'll think of 6 things as soon as we turn off.
I just have so much appreciated your daily videos. I think that a lot of people have, and it's just been, there's been a lot of days where I actually stay away from the media, CNN, BBC, and I just can't sift through it. And so I always appreciate your summary and perspective, and yeah, you've been like this grounding thing for me every single day, where I can tune into your video and kind of get some perspective. And yeah,
well, I appreciate you sticking with it for so long. You're obviously a very patient lady. So you're back at work tomorrow, Karli?
No, I'm back on Friday. So I usually work 3 shifts in a row, and then it takes me usually a day to kind of take it easy and recover. And I'm gonna raining today, but I've got some plants that I got to get into the ground.
Oh, and it's so therapeutic, isn't it? The first night work's just going.
Yes.
Like all the time, isn't it? Did I do that? Did I do the other? Just.
Yeah.
Oh, I've got one more question.
Oh, okay.
A bit of a naughty one, really. I think the immune system works best at febrile temperatures.
Okay.
And the culture in the UK for a lot of junior doctors and a lot of nearly all nurses, as soon as someone's temperature goes up, they're in there with the paracetamol, the acetaminophen, the Tylenol, the ibuprofen. Is that the culture where you are as well?
No, we're not so quick to dole out medication. Yes, antipyretics. We're not so quick to dole those out, but and in my practice, it's not the first thing I go and grab when my patient develops a low-grade temperature. But I found it interesting that occupational health here at my hospital is recommending Tylenol for those of us that may be running a fever. So I was going to check up with them on that and find out why that was their recommendation.
Yeah, I disagree so fundamentally about that.
Yes. I agree with you 100%.
Yeah, as if fever is a side effect of the disease, when it's such a deliberate mechanism that's built right into the hypothalamus and everything that's in the body, that your temperature goes up when you have when you have an infection. And I actually think that could make quite a big difference in COVID-19. The amount of people that become critical, I believe, we could greatly reduce, at least in adults, if we chose not to reduce fever. Because all the reports I'm getting indicate that the fever doesn't become too high. It gets to about 39.5 maybe, then it stops. People imagine it's going to go up and up and up and up, but the brain's smarter than that. It doesn't do that. So I'm pleased to hear your culture is not as obsessed with antipyretics as mine is.
No, and honestly, when patients get something like that brings their fever down, so they're given 1,000 milligrams of Tylenol, then I'm thinking, well, now I'm unable to track for the next 6 to 8 hours that whether our fever is going up or down or what's
you haven't got a clue, have you? Yeah.
Yeah. So I prefer it, unless the patient is has chills and it's really feeling miserable. I usually.
In England, we call it paracetamol, but it's the same stuff.
Same with my husband in Australia. It's been one of the things. Like, what are you talking about?
Yeah, most of the words are the same. I mean, it's like one of us spells things wrongly. I'm not quite sure who it is, but most of the drugs and things are quite recognizable, which is good.
Well, I hope so, because it may not be a long shot that one day I'm over in Australia practicing. So
Oh, you'd be fine. You'd be fine.
yeah,
Which part of Australia is it?
he's in Wollongong. His family's in Wollongong, which is about an hour south of Sydney.
Yeah,
So
Sydney. Yeah, yeah. My
yeah.
brother used to teach at Wollongong. Yeah, yeah,
Oh, okay.
yeah, yeah. Okay, so fascinating. Right, Carly, thank you. Really appreciate that.
So happy to have had this
Absolutely
talk with you.
brilliant.
Yeah.
So I'm going to put it on. I'll put it on to private, and you can decide
Okay.
if you like it. If you don't, no problem.
Okay.
I would
All
talk to you
right.
just for the
And
sake of it anyway.
if
It's
you put
absolutely
together,
fine.
if I'll be in touch every once in a while from time to time, and if you in the future decide you're going to put a team together or anything like that, you reach out to me, okay?
Yeah, I've no immediate plans to, but you never know. Yeah, absolutely. Yeah,
Yeah.
yeah.
Okay.
No, certainly that's wonderful. Yeah, no, that's great. And that's tremendous, Carly. Thanks. So it's great.